want to thank Sovereign House for and the Millennium P-testers, and I think that's great information about the fact that you can monitor, because part of the things I talk about is monitoring someone's behavior as they're going through the process of recovery, which certainly puts the family at ease. And I will, wherever you went, Kenneth, I will pursue that. You know, I was just thinking the other day, I was calling up Central Office AA, and they were saying, you know, we have all these fancy books and PhDs and everybody's letters, but, you know, it took a guy at AA to say, I was telling you about the lecture I was giving, and he said, oh, come on, he said, everyone who's an alcoholic has a mental illness. And actually, because I'm going to talk about this today, which is the DSM V, actually the DSM V this is it. Our lives are about to change, but not really, because we're the same when people are the same. I have it here if anyone wants to look at it. The DSM V is interesting. They're doing a lot of things right and obviously a lot of things wrong. No one's going to be happy. And that's basically to depathologize substance abuse. We no longer have substance dependence or substance abuse. They're not there. It's substance-related disorders. And really, when we're working with the family, our goal is to eliminate that piece for people to feel that they can hear the story. I mean, studies show if you want to teach somebody, they have to be able to feel vulnerable. They have to not have all the answers. And when you're living in terror of someone dying on you or treating you or some kind of insanity, or just watching a loved one get sicker and die, the problem is that there's that inner peace, and we know this also from just Al-Anon and the substance abuse, of that belief, especially when we're talking about parents, that I'm a horrible parent if I cannot solve this problem. I am a horrible parent. That's if people even have parents. I'm a horrible parent if because I did something along the way. They maybe did, but when we're first introducing them into our lives, we're definitely not wanting to add to that shame. And I think the way the DSM V has been presented is, even as we're giving them information, which really is one of our big jobs initially in engaging the family, is just giving them information. Is that even psychiatric, the major psychiatric publication does not consider an abuse a dependent. Things are related to it, or behaviors are related from the fact of taking it. So they're really on our side in the DSM-5 about as far as getting us to a place where we can sort of depathologize a lot of things. What they really want to do is they want to move people to a place where we're seeing our clients more as syntonic or dystonic. Now it has a little bit different kind of interpretation from what we had, which is the dystonic person is the one who knows they have the problem. You know, I drink too much. That's my problem. I don't do a lot of process of change. Anybody remembers Prochaska and De Clementi, the 4 stages of change: pre-contemplation, contemplation, preparation, and action. And but the syntonic is the one, and often it happens with the family, and definitely with a lot of substance abusers and those who are mentally ill. Who wants to be mentally ill? And that is, I don't have a problem. It's not that bad. All those defense mechanisms that get used to minimize what's really going on, well, you do that too. I mean, I know everybody in here has heard the gazillion excuses. And so what the DSM-5 is doing, which is kind of exciting, is it's taking people from, again, pathologizing them, and we're talking about them like, oh my God, a balloon died, I'm going to die. You know, they are perceived in the context of where that came from. So actually, when you look at the DSM-5, it's much more behaviorally oriented, certainly, you know, cognitively, and it starts off with neuropsychic disorders, because neurodevelopment issues, because that's where all the stuff starts to happen. And so it's a much kinder book in a lot of ways. I'll say a couple more things about it, but just quickly about me. I have a practice in Westwood. I am level 2 certified EMDR. I put together and ran the family and outpatient programs at Hazelden, New York. I have worked at several treatment centers around here, and, you know, like everybody else, trying to keep a roof over my head. So So I also want you to know that this topic is so complex that in October, I have the flyers out there. UCLA is giving us, I'm giving a 6-hour talk. What was I thinking? I'm giving a 6-hour talk on this whole issue, with much more in depth if you're interested. And also I put out their flyers. I'm doing a new 12, it's actually not new. It's the 12-step group I had when I was created in Hazelden to help the families of loved ones of anybody who's got CODs, or which is what I'm going to refer to co-occurring disorders as CODs. Any CODs who need help and aren't ready to really go into the 12 steps, or actually want to investigate more about the 12 steps. It's mixed with psychodynamic treatment, group fellowship, there's homework, a lot of dialectic and cognitive work in there as well. So if you have questions about that, please come to ask me. So, you know, loving someone who has COD is pretty difficult because she's agreeing with me. I love this. I like to do this. She's agreeing with me. And that is because these are very difficult people. Many of the mental illnesses occurred before the substance abuse, and the substance were used to self-medicate. We used to call those MICAs. And then there's the chemical abuser who becomes mentally ill as a result of using the substances. We used to call those CAMI. Not in the big book, not in the big book, not in the, it's not the big book, not in the DSM V anymore. So one of the things that I want to talk about here is I just want to give you oh yes, I've got handouts. I want to make sure everybody's got both handouts here. You've got the front one and the back one. I love giving out handouts to be used as you want and please. And so, in the lecture format, which I'm going to get to in just a second here, so you know where we're going. Okay. So we're going to look at what the therapist's role is. It's a wonderful saying. I can't remember who said it, but our job is to teach something its loneliness. And I'll discuss a little bit more about the DSM V. And I've divided it into a couple of areas. The didactic piece. This is the least threatening piece that we're coming to because we're just giving people information. You will have a lot of loved ones come to you who really aren't ready to look at themselves. And that's Ben, by the way, if you look at that. And what happens is that in educating them and giving information, they can take that in because the goal is, again, to drop that wall of shame. As long as that wall of shame is up, nothing's going to penetrate them. The mind, if it's not vulnerable. In fact, they have that in the big book, which is anyone fails if they have contempt prior to investigation. So what we're trying to do is give them the facts with no judgment of them before we go into deeper work and using different dialectical behavioral tools I'll discuss. And this is an interesting multi-dimensional, oh man, can I spell badly? Multi-dimensional family treatment, MDFT. This comes from a guy named Howard Little. It's very big in Canada, where I'm from, and they use it a lot in the East. And it's, again, it incorporates so many things we talk about, but it's been highly successful with adolescent drug users and delinquents. It has outperformed DBT and CBT. And so if we're talking about a lot of addiction about being a developmental problem, you know, people are stuck at the age they started, usually around 13, 11, 12, 13, then we're working with adolescents. And so I was thinking that it makes a lot of sense to take a look at this, and no one really talks about it out here, take a look at this as far as a form of treatment. It's manual-based, and I've got more information on that in your handouts as well. We'll discuss quickly about relapse, and if there's time left, I would want to do questions. So if you have questions, please just write them down so I can answer them afterwards. So here's just some statistics. They're pretty amazing about, and I think the numbers are always much higher than this, pretty amazing about all the connection of mental disorders and addiction. Blah, blah. Duly diagnosed have higher risk of violent suicide, ideation, and completion, property damage, and physical illness than either if only one disorder is present. And a little bit more. 61% of bipolars have, I call that substance abuse disorder, 5 times more than the general public. Some other numbers up there. So when we're working with families, we're looking at for every one person with COD, 10 others are affected. So we've got quite a lot. This is something that you can take into the workplace. Also, another area that's growing, where this is really important work, is work with the elderly. We're just now, again, they have it more down in Miami. Well, yeah, everybody retires there. But we're starting to develop different programs for the elderly because, first of all, half of them can't remember when they take their meds or if they took their meds, or it's life is so empty if they have access to pain meds, they can often just say that's enough, I have it. So their family is very affected and full of guilt and all that sort of thing. It's an area that they really haven't addressed much in this town, and I think it's a great career concept and business opportunity. And of course, the studies show that family involvement increases sobriety, the attendance of this is for the COD, attendance at outpatient treatment, medication adherence, longer periods of emotional stabilization. But like, what's the concept behind that? It basically is what we're providing or creating, which may not have been created before, just because of the reality of the family's wear and tear as a result of taking care of this person. Is we're starting to work back to, again, family systems concepts. If one thing moves, everything else moves. We're bringing the family to then work with the COD to solve the problem against the mental illness and against the addiction, versus everybody fighting against the COD. And we know that when people are creating a safe environment, that people have a better chance of staying sober and maintaining their mental stability. Okay, so what's our role? So fascinating, all the research that's coming out now, which is they're really finding that most modalities are kind of irrelevant. They all of them have mostly about the same amount of success. It is a therapeutic alliance. That is our secret. And the therapeutic alliance is really seen as flexibility. In other words, we, again, start off where the client is, but we don't start coming up with solutions until they're really asking. This is, again, unless we're in a real crisis situation. And of course, honesty. Carl Rogers did a lot on this, and genuineness, about our own struggle sometimes with a client. I'm here, I'm trying to help you. I seem not to be doing that. What can I do? And if someone is on some drug or situation that you don't know about, I'm not sure about that. I can check it out, but I want to give you the information I do have on that. Our honesty about our abilities and capabilities, and of course, Scott Miller and Duncan have done a big piece on how to check in with the clients as far as how we're doing with them. I'm not going to go into that, but it's in your bibliography. Respectful, trustworthy, showing up on time, doing our notes, sending our bills, and we say we're going to do it for our clients. Confident, I have a lot of tools in my box here and I can help you. And interested, isn't that odd? This is one of the reasons why early interns in the business sometimes do better than we well-seasoned ones, is because they don't have a lot of tools, but they have that passion of interest. They're curious. They're really, the person really feels that they're there to try to make them feel well. And we come in, throwing these personalities. Access 2 and Access 1 is gone. Not even in the DSM V. Throwing these Access 2 opinions at people, and we start to get a little jaded over a period of time. So, interested seems to be one of them. You don't have to have a lot of letters behind your name to be interested in honoring somebody just by listening to them. Again, they find that in success in therapy, 40% is the client. If your client has these issues, they're going to do better. 30% is of us. 15% is placebo, and the other percentage, I can't remember, it's so small, no one cares. Okay, so let me go into the didactics, and as you go through and follow along, what we're trying to do, and I was talking about systonic to dystonic, what we're trying to do is motivate loved ones to stay in treatment,
And not necessarily the COD, our focus is on the loved ones to stay in treatment. Ironically, as they do, the COD often does, but often they don't. Often they just don't have the capability, they're living under a bridge for whatever issues going on. So, and that's basically the removing, according to Prochaska and De Clemente, removing people from the stage of pre-contemplation where there is no awareness to contemplation. DBT calls it pros and cons. Motivational interviewing, basically lists has a list of, has you list what's positive and what's negative. And if you go, these aren't numbered, but you have when you find it, you have an over-functioning worksheet, which basically helps someone to sort to look and see what is going on in their life. And even if they minimize it, they're having to think about it. Again, most of this homework is incredibly sophomore. Anybody can do it. And doesn't take a lot of time. Sometimes it's best initially when your clients come in to have it done in the office with them. Oh my goodness. In the office with them. And the other thing I have too, because also part of our role is assessment, is on the page before, no, 2 pages before, I have this chart, the FACE chart. We have a page for the COD or the drug dependent, and I came up with FACE. And of course, they all these things, most people get 100% on. And then at that, but I don't introduce that until I sort of had them examine where the effects of life have been. And basically, when we're talking to families, again, our first piece of our goal is educational. It's the parallel process and explaining to them, but by the time they might have found out about the substance abuse, or they're really aware of the mental illness, this has been going on for quite a while. And they're coming in without having a lot of information, but things are usually worse than they realize. And so we educate them that the other piece of that parallel process is the person gets sick, they get sick, but as they can start to get well, systemically they actually can move the COD to improve, at least improve, if not even get better, and maintain sobriety. So our goal is, as I told you before, is to remove the blame and shame. How do people learn best? It's when they're vulnerable. So we need to educate. And let me go back to this. I have my, the second handout, which you got. You should have a second page there, which is the Anderson Arc of Recovery. It looks like this. Obviously, I named it after myself. Or Lonnie Anderson, one of them. And the Anderson Arc of Recovery. When I was working at Hazelden, I put together their family their outpatient program. I was really frustrated because, again, I was dealing with a lot of family members who just really were in so much shame and anger that they couldn't actually, they just couldn't hear it. They didn't hear anything. So what I discovered was, if I explained, it's like when you have someone whose kid has a broken leg, you take them immediately to the emergency room. Because they know they don't know how to set a bone. But for some reason, families and people and loved ones and workmates and lots of friends think that they can solve something that's incredibly complex as mental illness and addiction. And when they come to us, they don't, again, for their own needs, they're often minimizing how bad things are. But the very, very fact that they're not capable of seeing how serious it is partly because they can't really look. It's part of their denial. It's part of their safety net. But we don't call it denial. We don't, again, come in with any judgment. We just say, well, let me show you this and see if this starts to make some sense for you anyway. And we start with the circle, and usually I put between 9 and 15 in here. This is for substance abuse, but also is for mental illness. And I say, it's basically caused, both of these issues are caused mostly by DNA, genetics, hormones, neurochemistry, brain trauma, emotional trauma. So the person is sitting there thinking, especially if we're still, and we are, we're pretty sophisticated. We forget. Most people still think that it's a moral failing. Why can't they pull them up? What's wrong with them? And it'd be, again, we say, like, being upset with somebody with a broken leg that they can't run a marathon. The body won't let them. And that's one of the things, again, in destigmatizing this and apologizing to families. We really want them to understand the physical components of this. So it's not that they're doing it to them, it's that the person within their own physiology is doing this to themselves through these conditions. Of course, the DNA is the genetics. There's a ton of history about that that's out there now, thank God. Emotional trauma, PTSD, brain trauma, TBI, I mean, all the veterans coming back, and the mental illness plus the, again, people use to escape feelings. And that's in the DSM 500 neurodevelopmental problems. The neurochemistry, of course, explained to them about serotonin and depression and what dopamine does and which drug affects those things, so the person needs more of it. And of course, hormones coming into puberty, and also as we age, there's a lot of more fatigue, and people may be taking, you know, a little bit of speed to keep going, and all sorts of different forms. They now have caffeine-induced disorder in the DSM V. So what happens is one day the person is under all, and it's whack. We're gonna get some more. So what happens is life goes on, and there's some stress up here, and the person discovers that when they use a substance, they solve that, they get immediate relief. Immediate. So not only is the brain chemistry supporting this, they no longer feel those feelings, they're numb, and we know all the stories of I feel like I belong. But most important when discussing this is that the use is either to increase a feeling that's good because a person's afraid of feeling badly again, or just they're feeling so badly they're trying to escape that. This is the information the parents need to, because every time they look at their COD and they think that, you know, they're just doing this to me, or they're just a damaged person, you're not going to get through. So the more we can talk about this, so the brain chemistry that changes. So now you do that enough times, it takes 21 days to start to put a nice little pathway. By 40 days, it's right there in your memory, well, in the hippocampus, in the memory part of your brain. So what happens is the next,
40?
What's that?
Someone said how many days?
It's about, well, 40, 20, it's, you know, it takes about 21 days to get the action going, get the chemistry going, and about 40 days to get it right in the hippocampus. That's the one that holds the memories. So what happens is now I've created a habit. Now I know that if I'm overwhelmed, all I have to do is take this substance and I get to feel relief. Now, what we explain to the family is, the problem is they don't learn the life lessons because they've got a solution and never go to the other side of maturity, life balance, taking responsibility, learning to accept things as they are, all these basic tools of mature development. So when I'm explaining to them, you know, how are we going to do this, they say, fortunately, you don't have to. We have several things that we can do. One side is for the person with the COD, and the other side is for the family member. And obviously, with the person who's sick, we want to stabilize them. They may need medications, therapy, 12 steps, peer support, family support, and activities that bring them pleasure. And for the family member, first of all, understanding the facts of, it's going to have to be COD now, COD, self-soothing techniques. Now I'm going to show you some later on, self-soothing techniques that they can use on themselves when they're overwhelmed, and also use with their loved ones when they seem like they're starting to get out of control. 12 steps for them. NAMI has an incredible program. It's also on your bibliography. It's family to family, and you can go and connect, and the families can connect with the families either at meetings or on the internet. Family and other relations, and also self-care for the family. Before I go on, any questions about this? Yes?
Looking at this art of recovery on the side of, my sister is still using, she'll be 63 in October. And my father was an alcoholic, and my brother was an alcoholic. And she's still actively using marijuana. But before, she was like everything, I mean.
Which is a garbage head, you mean?
Everything.
Okay.
Drug dealer, just the whole nine. So I see her on this because she had emotional trauma. Her father molested her, and she said that her cousin raped her twice. But she's never had any treatment, no therapy, no nothing. She says, I can't sit in a therapy room because I'll have a panic attack. And I said, well, Tisa, they will help you work through the panic attack, but she just doesn't want to go. And hormones, I don't know, but it's I've always been puzzled as how it skipped me, because I have no addiction.
You can skip a generation, but you can get the other piece of it, which is, I hate using that word, codependency, is the emotional fear.
Oh.
Of fear for your sister.
You know, I think I've worked through it.
Okay, good.
I've worked through it in my 20s.
Good.
And now it's about just, pray. That's all I can do.
Well, it's also the understanding. That's why I'm very specific about these things, because the final thing we're telling families is these are not attended to, and these little bricks start to fall down. It's no longer supporting the person so they can keep getting to the other side. So they're not, as long as they're doing this over and over again, they'll start to habitually create tools that are going to allow them to calm themselves, to handle life on life's terms, as we call it. But as these start to fall down, and especially when we're talking about COD, is a high risk of relapse on both pieces, the addiction and also on the mental illness due to the fact of not wanting to take the medications, but also that many other people are on the street. I am actually referring more to middle and lower middle class population with this. I'm not talking, because all of this is on a spectrum, from cigarettes and depression to smoking crack and schizophrenia. So, but explaining to them that if these are not maintained, these bricks don't maintain this, the person will eventually, because this memory is in the brain like a bicycle. All of us know, we go years without riding a bicycle, but all of us know once we're on the bike again, we're back on. Same thing, when they're not getting the support to go to the other side, that memory is still connected. When in pain, I pick up. So if we don't make it clear, because a lot of family find it very hard to say, why are you still going to those meetings and all this sort of thing. That's why, and that has to be part of our educational piece on this. Okay. So the other things, very quickly, is we want to teach about what causes addiction, as we did here, but also, and mental illness. We want to go through the different kinds of addictions. We want to let them know what kind of substances they are, what the signs are, because most people are not aware of the signs. Real basic information, because that's going to give them some strength if they feel they're in the know. If they're really truly in the know, they're going to start to become more vulnerable and hear more and want to hear more the next week and stay in treatment. And I discussed it with non-pathologizing, and we talked about the substances. And the last didactic task. Very quickly, one of the things our job is to help the parents and friends set boundaries. There is no boundary without a consequence. I'm not saying punishment, I'm saying consequence. But contracts signed and stuck on the fridge. I've done that with a lot of families, give the magnet, stick it on the fridge. Everyone has to sign it. Contracts of behavior and the consequence. And the best thing, especially when you're working not only with children, but also with adolescents, but with adults who are dealing with this, is you get them to help make up the consequence, which is usually worse than anything you would ever come up with. And the boundary is something that is set to protect the quality of the family and not to punish the person. That's why I use the word consequences. Because a consequence is only the result of that behavior. Because what we're trying to do with the COD is get them aware of actually their part in creating. Like if I don't take my meds, okay, I might put on some weight, but I'll really want to jump out of that window. Self-care, of course, Al-Anon, I've got a whole bunch in the back of this of resources. I've got Sovereign House in there. I've got a lot of different places, resources, and also in the bibliography. I've starred all the books that are good for your clients to have. You'd enjoy them too, but they specifically get them to get these books. One of my favorite, and I tell you, it keeps going, Melody Beattie, and The Language of Letting Go. Keep it easy. It's a daily reading. It's a daily reading, and show them they just go to the index when they get overwhelmed. But I've got all that information for you to pass on to your people. So, dialectical therapy. Okay, so what does it mean, dialectical? It means it's two different ideas brought together to synthesize into something new from philosophy. And basically, what it's saying is that I can have a point of view about something, like I don't like to pay the IRS. The other side is, if I don't pay the IRS, am I willing to pay the price and have to do it if I pay the IRS? No. So I'm allowed, this is called radical acceptance, so I'm allowed to go to pay my IRS, and if I want to not be happy about it, and bitch and moan about it in lecture places. So we're allowing the person, again, we're getting back much more to this person-oriented therapy, which the DSM V is helping us with, is really going where they're at, allowing them to have the freedom, because one of the most difficult things, not just for the COD, but for the family, is you're searching for a sense of autonomy. And certainly adolescents are always looking for, you know, a sense of autonomy. And if they're allowed, as they say, to come up with the consequences, if they're allowed to not like what you're telling them to do, but they have to do it anyway because there will be a consequence, they start to feel some power. So the whole family starts to work together as a unit to fight a lot of, I always call it a battle, but to, I guess the answer is when you start loving the disease a bit more, it's not as evil as you make people out to be. You have it. The mindfulness, I have some, I'll show you that later. Mindfulness is basically about having someone observe, participate, and describe. And I think there's some notes there on the DBT. And it's, yeah, there we go. Sorry about not having numbered pages. Here we go. Okay. Mindfulness, observe, describe, participate, and protect. That's this page. And protect, because the mindfulness, if I'm aware of what's going on, I'm also aware if I'm in danger. And especially with people who are dealing with trauma, this is essential. Pros and cons, cost-benefit analysis, again, the MI. What's good about me not wanting to stop giving my kid money? I mean, we all do something for a reason, even if it's dishonest. And the fact that when I do give them, there's this problem. And really, without judgment, which is also part of our therapeutic role, examining for the person, so they're obviously arriving to the decision. That's our basic role as therapists. Behavioral chain analysis, you see these in CBT. What was the antecedent event? Albert Ellis, wonderful guy, crazy as a bed bug, but wonderful, wonderful man. Talks about it as the activating event, the belief that comes out of that, the emotion that comes out of that belief, the action that comes out of it, and D is coming up with a disputing belief on that. Turning the mind possibilities, this is, certainly we can put it under mindfulness, but also some kind of meditation. Turning the mind is when you're sitting there and you're saying, okay, what's another way for my mind to see this? Okay, once I pay the IRS, then I don't have to worry about it for another 4 months. Okay, and it's done. Okay, cleaned up some stuff, I'm free now, I have free time. So we're constantly, it's not Pollyanna, but we're constantly turning the mind into something to start to change those perceptions into what is something that I'm actually gaining by having my tooth filled. None, I don't think. And of course the acronyms, which I have them all here, and they're divided, I'm not going to go into them now to save time, but just give, some are about dealing with others, some are about ourselves. I like the building mastery and self-respect under improve. I means imagery, so visualizing myself in a place where I either was feeling very powerful. Also, one of the places EMDR can be really terrific because it's just used to anchor that experience, that physical experience when the person, you know, won the award or won the race or something like that. Because we're trying to anchor in more positive beliefs about a person, especially if we're dealing with some of this COD. And we're not even going to trauma, but EMDR can use it. I use it a lot in that method for people in the recovery. M, what's the meaning? What meaning am I giving this event that might be inaccurate? This also, I want to just quickly talk about somebody named Byron Katie. She's a very wise woman, and it's in your second section here. She has a belief questionnaire. She talks about, I think, has some of the best therapeutic questions that exist, which is, who would I be without this thought? What would I be doing if I didn't have this thought? Can I prove that this thought is true? And there's one other, there's 4 of them. It's in there somewhere on this page. Can I prove that it's true? And here, yeah. That's must be in the other. Anyway, how can I prove that it's true? Very powerful. She's in the bibliography as well. So simple, but really starts to jolt the mind out of its emotion. You know, how do I know that it's true? The IRS is going to be broke. I really don't know if that's true, but I feel it. Okay, what would I do if I knew that it was going to happen? I probably would feel them. Okay, and what would I be doing? Well, once I did that, I might go to a movie or buy some diamonds or whatever it is. So we're, again, this constant move, and this is also with the CODs as well, this constant move of reorganizing perceptions through questions versus saying, you know, that really isn't helpful to you, or that doesn't make any sense how you do that, which is, you know, when you get tired at the end of the day, sometimes that's what comes out. So obviously prayer, there is and praying with others, relaxation, lie down for 10 minutes, breathe 5 minutes, 2 minutes, improve. Oh, I love this one thing at a time, just focus on what needs to be done in the moment. Vacation, just taking 5 minutes of a walk is a vacation. Something, again, that's changing your perception. And not an addictive thing like getting back on the phone or the internet or something that just you're sitting with yourself. And encouragement, so important, finding cheerleaders. So you've got those to play with. And the people who do the DBT experience really get these acronyms down. Not very hard. Okay, so in DBT, our targets are our treatment. I kind of covered this. We collaborate with the client on creating goals, and the goal is for them to develop interpersonal skills so that they can know how to handle being around others when others aren't doing what they want. Emotional regulation skills and distress tolerance skills. Now, for the family member, these tools are very, very powerful because you're going to start to teach the family member, all right, if they're in a state like this, do you need to have an estate plan? Do you need to have your keys by the door? Do you need to have a purse, your purse and your keys? Do you have a place to go that's safe? Do you know about 911 and 5150s? Do you know what that really means? Have you got a shelter nearby? So you work with them as far as interpersonal skills, which are also about self-protection, but also how to be observant, you know, get them to go through a recipe, step-by-step process of the person who's got the COD to start to see when they're starting to get elevated in their mood or dangerous or whatever it is, and coming up with a plan. Emotional regulation skills. Well, I don't know too many people who love and care for people who have COD who aren't exhausted and hopeless. And this comes to some of our other work with the families, which is also checking in with them and seeing how they are doing in their own state. Do they need a therapist? Do they need some psychiatric care? What is their level of self-care? Because what you're saying to them is the old thing in the airplane, you know, take the mask then on the kid, is that you have to be strong so you can take care of this. It's a very huge task. If you are not strong, if you cannot handle this person, you call 911. And when I mention that to people who I'm just lecturing to families, boy, they get upset. And because of the shame, they feel that they're betraying, all that sort of thing. And it's so essential to remind them, we want them to be dead or trying to attack you, or do you want them to be upset for a while until they maybe stick in treatment and you can work this out as a family. And of course, the stress tolerance skills. Right in front of what the DBT is, I have impulse control tools. Oh, no, I don't. I have the 12 steps. Okay, impulse control tools.
It is in here. I saw it in here.
How about not having noticed here? Okay, so impulse control tools are right at the bottom of all these acronyms. So basically, I sort of called together a lot of different techniques from different resources, because basically, this is the brain on drugs, and you have a brain diagram right underneath your Anderson arc of recovery. Okay? And it's good, it's interesting, and sharing this with families again, showing them how the brain works, this again is showing them this is not a characterological issue. Something's happening in the brain. So here we go. Here's our little brain. It's not that big too. And if you notice, there is in the midbrain, on the right-hand side, there is our limbic system. And our limbic system, we go to the second one, has all these fascinating little glands that affect our release of adrenals and cortisol. And what happens is at the tip of the hippocampus, where a lot of the memories sit, is a thing called, about the size of an almond, called the amygdala. Oh, P.S., and that's another thing about the DSM V. They really are coming much more from brain science now, too, to explain a lot of issues. So basically, the amygdala holds those dangerous memories. Like if I saw the saber-toothed tiger eat my friend, next time I saw a saber-toothed tiger, I'd fight, flight, or freeze. They're dead. What happens when that's activated is it goes to the hippocampus, which tells my pituitary and my adrenals and everything to pump out the adrenals and the cortisols. I tighten my muscles so I can run faster. My blood vessels tighten so if I'm bitten, I'm not going to bleed as much. I'm able to run faster, but you know, if it's all here and there's no more saber-toothed tigers, what happens is people get stuck. Also, people who've had trauma and enormous stress, that those levels of cortisol get stuck, and we know that that also affects the immune system. So what happens is when this in the brain scans, when this area of the brain is active, this area of the brain, oh, it's sprinkled a bit over here, the right side, right behind the right ear and the right eye is where this is, the limbic system. On my left side, remember this is the last part of my brain to develop. The limbic system is still part of my reptilian brain. It's very reactive because it's all about survival. The left side is where I am logic, consequential, judgment. You know, if I just had a left side of the brain, I might be autistic, or at least appear that way, because there's no emotion that's covering me. So what we know in the brain scan is when the limbic system is active, is hot, the thinking part of my brain on the scans is black. It is inactive. I cannot access any solutions whatsoever. Now, what the old story is, well, can't you just think yourself out of it? No, you can't, because you can't think, because it's not working. What the new work is that we can work through our body. We can lower, the moment we start lowering those adrenals and cortisols, we start breathing more deeply. The temperature comes down on this guy engages, and now I know exactly what it is I need to do. So how do we get people to do this? And again, we're moving away from saying, you know, you should have thought better. You can't think better when you're in fear or danger or overrelated. So what we do is, I have these impulse control tools here, and I'm going to quickly go over them. Basically, it's part of mindfulness, putting you in the here and now. But as we're doing it, what we're doing is we are slowing down the cortisols. And what I do when I'm working with families and the CODs is I say, do you notice when your body tightens, it usually your chest or your left? I said, that's where we're going to intervene, not until you're aware there's a problem. And we start, somatic work is very powerful, and this is really well. Really being connected to when the body starts to have those signs, because the cortisols are already running. Because we get something like, I have the facts somewhere, I can't remember, but something like, 110,000 bits of information into the brain through our eyes, because the eyes are connected right to the hippocampus. I mean, our brain is responding to what we see. We only are conscious of about 48 of them. I mean, it's that kind of percentage. It's not exactly right what you're saying, but it's that huge percentage. So my body's going to start putting out hormones and tightening up before I even realize that, I have a thought that there's some trouble here. So what I want to do is I want to slow that down. How do I slow it down? We get in the moment. The first one is location exercise. Get your client, and everyone can follow me. Look at the farthest thing in the room. And you train them to do this so they can do this with themselves and their families. Okay, and you just say, just repeat yes after me. Do you see the lamp? And you have stubborn teenagers that go, let it. Just think, then you say yes to yourself. It's fine. You wouldn't know. Do you see the fire thing? Do you see, yes. Do you see the projector? Yes. Do you see the tables? Yes. And you start saying, and you start pointing out more things, and eventually you come up through the carpet to their shoes, up to what they're wearing, jewelry, whatever. And I always like to get them to look at their fingernails. There's something about turning the hands and looking at the fingernails that really gets people focused. Already there's calming. Already there's softening in the body. The other one is the five senses, just basically going through the five senses. breathing exercise, everyone has a million ways of doing this. We want, because in the state of that hyperarousal, we are hyperventilating. We are getting too much CO2 and not enough oxygen. So we lower the CO2 by holding in the breath. And it's not, it's, you know, tell them to relax their shoulders, just gently breathing through the nose for 5, I say hold for 10, and then out for 50, like you're blowing out a candle. Now, Lee's technique is pretty evolved, so I'm not going to get into that. It's on the, it's basically approving of your fear, your anger, and again, it's like when we look at our dragons in the face, they disappear. And it's very powerful, but I don't have time for that now. So, okay, and mindfulness, okay, and that's some of the distress tolerance skills. My main concepts we've already discussed. And we just got, the wise mind. The wise mind is, we have a very rational mind, let's say the left brain, and we have the emotional mind. And when they're combined together, we get the best of both. So often, you know, when we make representations to people, sometimes a higher power, whatever, often we're sitting there and saying, well, what would your wise mind say? We want them to walk away thinking that, knowing they have the power to access their thinking. And something occurs when I say, go to, you know, what would your wise mind say? They go back to the left part of the brain, and also their instincts. They're mixing the two together. And constantly throughout, we're doing continual pros and cons with them as they move along. So how is this working? What's working for you? What's working against you? We're trying to create what they call mental maturity, is being able to hold two opposite ideas at the same time. I hate the IRS, but I have to pay the IRS. I may not feel like I'm the greatest person in the world, but I do know I've achieved some things in the world. Creating that balance. And so behaviors that we want to increase are certainly the self-regulation, which we've talked about, and we've also talked about that. So next. Okay, let's get on to, I know it's fast, but when you get home, you know, most times you go home and throw these things out. Don't, because there's a lot of things you can give your clients on this. Xerox it. Thank God for Staples. All right, so multidimensional family, you're going to hear so much about the same stuff in here, but it has such evidence-based success, especially with adolescents. I'm just overwhelmed with the studies I've been reading about it. Some guy named Howard Little, you can actually, the number is on your thingy, you can actually go and get the training. It's manual-based, you get the manual and all this sort of stuff. So it integrates, again, it's much more of a social work kind of mindset. It integrates 4 core areas: the client, the family, the friends, and the community, and that can include judicial and medical systems. So everyone is now kind of connected to having information. It's not like I just have the information about the medical place. The family does. The COD does. And getting them all to communicate, because that's part, as we know, part of the illness is also keeping secrets. And it also makes the person feel more secure. They may not like it, but psychologically it's been proven that they feel much more secure knowing people are on them and monitoring them, and that they have a say in their outcome. You know, we're not treating them as crazy people. We're treating them as people who have issues that can get better. So there's these foundations that they have, which include, we want to facilitate change systemically. We've already talked a lot about that. You've also already got a lot of tools and training. CBT is great on that, pros and cons. Goals are to improve communication and negotiating skills, setting limits, boundaries, consequences, and monitoring. And I'm not just talking about doing UTs. Monitoring how it's going, the family, the friends, saying, oh, how are you guys doing? Do you still trust me yet? No. Well, what would I have to do to make you trust me? Or from the family members, you know, I know we're setting these consequences. You know, you seem not to be making it. Do we have to create a new contract? And again, we discussed it. That's in the arc of recovery, and what we talked about is knowledge of the family, physical, mental, and substances. And this is a nice tool they have, which is using day-to-day events, like having a meal around, and using intervention that, okay, next time you go home and you're sitting around with your family, everyone has to discuss their vacation. And everyone will make, especially the kids, go, But that's okay. They're not supposed to like anything anybody says. But everybody gets involved in discussing what's going on. And if again, while you're creating this, you're saying, what if someone decides not to do it? What would you as a family like to do to handle that if they don't want to be engaged? And you get the person who's probably a troublemaker, the COD, to come up with the consequence as well. And again, for the goals for the community is we really want to build a protective factor, reduce the risks, get the school aware. I'm shocked sometimes when I'm dealing with schools and parents are unaware. You know this one. Parents are so unaware of what's happening in the school, and there's this, unfortunately, has been created this rift between parents and teachers for some good reasons. And that is not creating a protect, because you know they're splitting. Boy, those kids will figure out how to turn you into the bad cop and the good cop. So our responsibility is sort of what we've talked about, to enhance the motivation, promote participation, assess the effects of outside interventions, you know, as we brought in this medication, how it's happening, how has the family observed the changes in the behaviors. And therapists, we advocate for the system, not for the individuals, so no one feels that, you know, I'm here for the family, not for your mom or your dad or you particularly, which will upset a lot of the narcissistic CODs. We're going to make this work as a system. I'm here to help the system. Same thing when you do couple work. And reach for it. We're either going to do tough love or try to save that child. And these are our own issues. You know, they come up in our own countertransference experiences, and this is again why, you know, supervision. I still have a lady out in New York I speak to once a month, just to check on my own madness. Now, relapse. This should not be, at this point, this should not be a shock. Because at the beginning of treatment, you're examining what the expectations are of the COD plus the family for outcome. Because especially with CODs, there is a high rate of relapse. How we reframe it is we discuss that as being a learning point. That is something that we can see, kind of start, and I call them recipes for relapse. You know, what is your recipe that brought you to that? Well, you know, my mom was angry with me. Well, what was making you angry, and what brought you to that? So everyone is sort of under the same sort of judge is asking them all the same questions. So what can we change in that? Then again, in early recovery, we want to start coming up with a pre-plan. Because once we get the parents understanding that just because the relapse has occurred does not mean that the person may not get better, it's part of the process, or that the person is not respecting them or all those issues, I think it's characterological, is that the pre-plan sets everybody up and the COD for knowledge of consequence. You do a contract, you sign it, put it in a frame, stick it on the wall, put it on the fridge, whatever works for the family. But this needs to be done very early in treatment. And it's not just for the, and the COD will love this, it's not just for the COD if they relapse, but what about if the family relapse? What if mom and dad start fighting? Also, and I haven't even discussed this, the issue of parents using and what that means, you know, they're prepared to do it. And, you know, allowing the COD to come in and discuss, you know, have you ever considered about anybody else's drinking? They love that. They can point the finger at everybody. And, but again, this is an early treatment. You know, what are you giving that's a mirror to your children in behaving? If you are drinking and driving, it's not against the law. If you just drink and get in a car, but if you're going to drive, you want to show your kids how they're going to be when they drink and drive, and you're going to get someone else who's sober. You're going to DD, call them designated drivers in Canada. And renegotiate behaviors, contracts, and expectations. And if the worst happens, and I think this is the elephant in the room when we're working with families, what if they die? And that if we don't discuss that, we're not dealing with their deepest fear, and sometimes our own deepest fear, you know, with our clients, because it does happen. And what if the worst happens? What do you need to take care of yourself? What is your support system? You know, I'm here for you. Yes, it does happen, and I'm not saying it's going to happen here, but I think you have to be aware of this monster that you're fighting, and it sometimes will kill them. Because it's in their heads. The moment they have a problem with their kids, every mother, father, boyfriend, girlfriend, boss, they say, when the guy dies, and I lose all that brains, you know? That's really the elephant, and it takes a lot of courage. I would recommend you speak to peers on how to do it, and other ones who have done this, but that really needs to be addressed. So, I think we're done. come up, even if you look through some of your pieces here, if you have any questions about this. My typing, why can't I get a computer that's up right? Any questions?
I have a question from
Yes.
the very first part. When you said what we all know, but you said something I didn't know. You said that the most effective aspect of therapy is the therapeutic alliance, but that the patient, 40% of what core features or so that they bring to the table
I think it helps, it actually is the piece, it's
is
not us.
the important
Yeah, then it's us.
piece in facilitating
Yeah.
the therapeutic alliance. And what were those core features?
They were, I have them here. Hang on, let me go back to the beginning. Basically genuineness, trustworthiness, showing up on time, being there for what they say.
Interest.
Interest. That's the big start.
For the therapist, but that's for the patient.
No, we're doing that to the patient, to the patient. That's
Yes,
our
that
role.
I understood, but you said there were characteristics.
Right, like they have resources, they have money, they they don't have a lot of medical problems. They're actually motivated to come into treatment.
Okay.
But the fact is, if that's not happening, then we're the only show in town. And that's the hope. And
So we're modeling for them. I understand that, but I misunderstood. I thought you said there's a piece the patient must bring and they're really going to.
well, if they can bring it. I mean,
In their own treatment.
you have someone coming in who's got HIV and it's not being addressed, or you have someone who has no home, these daily life issues need to be addressed first before you go, maybe they just need to get sober.
Oh, of course.
And so, you've got a family who's living in a shelter, they don't have a lot of resources. So one of the things, and this is again from the social work training, is we get them connected up with agencies.
Mhm.
So they can get strong enough to have at least, some time in their brain to, some space in that left side of their brain to start to solve their problems. But when you have a client who has a lot of those resources, they are about 40% of the reason it works, because they want to follow the directions. It makes sense. Any other questions?
Thank you.
Okay, I will, there's the handouts are back there. I also want to remind you that what Viktor Frankl said, and this is something to share with families, and he was the one who survived the concentration camps, and he became a psychiatrist and tried to figure out why some people didn't kill themselves afterwards and some did. It's because they found a meaning to their lives. He wrote a book called Man's Search for Meaning. It's about that thick, and I highly recommend it. It's on your, maybe I can put it on your list. But basically what he says is how we take care of our own tragedies is by being there to help others who've gone through the same.
The Dalai Lama said that.
No, I've said it. I was the first one. Right, thank you all very, very much.